Hi, everyone.
I'm Lisa.
And I'm Steph.
And together
we are PD Connect. Thank you so much for being here today. We have Dr. Martina Mancini joining us, and she's going to be our guest speaker.
See.
Yeah. Oh, you're just, okay. Mimicking. Okay. All right. So thank you for joining us today. We're so thrilled to have you all. Just to let you know, we're PD Connect. We are a nonprofit in the San Francisco Bay Area, but virtually wherever you are. And we teach exercise and education. And we'd love to have you join us at any time. You're at our speaker series, which will be available on YouTube. And we'll also send this out in our newsletter this weekend. So join our newsletter. You can check us out at pd-connect.org. All right.
Wonderful. Yeah. Well, before we get started, we are going to talk today about walking and balance and Parkinson's. But first, we'd like to introduce our guest speaker.
Yes, welcome Dr. Martina Mancini. She's a co-director of the Balance Disorders Laboratory at Oregon Health and Science University, or also known as OHSU. She is Associate Professor of Neurology and Adjunct Associate Professor of Biomedical Engineering at OHSU. That's impressive. Dr. Mancini is a bioengineer focusing on the use of technologies to characterize and treat mobility impairments, such as freezing of gait in people with Parkinson's disease. She is investigating the neural correlates of mobility changes with technology-based approach for rehabilitation. Dr. Mancini received her BS, MS, and PhD in bioengineering at the Alma Mater Studiorum, University of Bologna, and her post-doctoral fellowship in neuroscience at OHSU. Amazing.
Wow.
Thank you for being here.
Can I just say a little fun fact?
Yes.
You know, it has been thought that the University of Bologna is the oldest university in the world. Established in 1088.
That's incredible. Okay, well, thank you for sharing that fun fact. Doctor, thank you for being here.
And we're going to spotlight Dr. Mancini.
Lisa, Steph, thank you so much for the very kind introduction. It's a pleasure to be here, and it's a pleasure to see so many people joining. I'm really honored to be talking, especially in this month that is supposed to promote a little bit more awareness. So I'm going to share my slides, and I apologize because I have a little bit of a cold, but when you have a 2-year-old, they just get you sick whenever they get sick, or whenever they have a cold. After a few days, you have a cold. And so I'll go through and I'll try to be as clear as I can, and questions at the end. So the topic we choose today was walking, balance, and Parkinson's disease. I will be kind of like reviewing a little bit of the literature, as well as present some of our own data coming from our lab. And first of all, we do focus on balance and walking because they are among the factors that you can modify to improve independence during daily living and to try to decrease the risk of fall. And so I will be going through some kind of like timelines also on how things are changing. As kind of like objective summary for today, I will be outlining a little bit of gait and balance problems in people with Parkinson's disease. What do we know about progression of these impairments through the course of the disease? A few practical guidelines for rehabilitations, and some of our ongoing research that is conducted virtually that I hope some of you can join us in. So first, when we talk about balance and gait, we talk broadly, and oftentimes we do not realize kind of like what constitute balance. Balance is not one thing per se. It has different aspects, and we call those one transitions. Basically, when you are standing still and you are about to start walking, that is a postural transition, and turning as well. So when you are changing from one posture to another posture, sometimes there are adjustments that we need to make that makes keeping balance a little bit tricky. Automatic postural responses. If you are in the bus or in the train, you are standing up and suddenly the bus or the train stops, you kind of like have to adjust for it to recover your balance because it's an external perturbation. There is another kind of balance that is standing and postural sway. So we measure continuous adjustment that you cannot visually see, but that occurs in order for us to keep our upright balance. And that is important in daily life when you are standing on the kitchen and making yourself a tea, for example. And then there are aspects of balance that are more dynamic when you are walking. It's basically moving your arm, the orientation of your trunk, and kind of like all the lower limbs variables as well. When we talk about gait or walking, it's also not only one single thing. There are several aspects of it. One aspect that is the one that is most looked at is actually pace. And often we know that walking tend to be a little bit slower with shorter steps in people with Parkinson's disease, but it's not the full picture of the walking. And sometimes a slow gait might mean a little bit safer gait. There are aspects of rhythm, basically how much time you spend with the feet on the ground versus the feet not on the ground while walking. There are aspects of variability, which is how different is one step to the other. And they have been associated in the literature with fall risk. Asymmetry aspect, maybe it is reported sometimes that when Parkinson is affecting mainly one side, there might be also one side of your body taking shorter steps compared to the other side. And also that stability and upper body with slower turns and more steps needed to do a turn, as well as small arm swing range of motion. But what do we know when those gait changes occur across the spectrum of Parkinson's disease? And when they occur, they stay there or they go away, or are they basically fluctuating or not? So the answers are mixed. What we know from a lot of cross-sectional studies is that there are aspects of variability of gait. So how similar is your walking across kind of like the day, that tend to be different even in prodromal or pre-diagnosis of Parkinson. And then in early stage of Parkinson, there tends to be aspects of upper body, reduced arm swing range of motion, asymmetry, one side dragging maybe the other side. And then there are aspects of rhythm, aspect of pace and turning and stability and upper body that tend maybe sometimes to be impacted from a little bit mid-stage Parkinson until later stage. FOG, or we refer to it as freezing of gait. If you are treated with levodopa medication, sometimes is occurring in later stages of the disease. If you didn't take levodopa medication, then it can also occur in earlier stages. We consider it to be one of the gait disturbances, maybe a more severe manifestation of gait disturbances compared to slow gait, for example. And this kind of like overview comes from data that we collect in the laboratory. And we do know that there is a little bit of bias collecting those data, because when an individual with Parkinson, but also with another neurological disease, or even a person that acts as a healthy control, when you are being seen and you know that we are measuring things, we tend to perform a little bit better than what we actually perform in daily life. And another note, we found that sometimes we look at people who could develop Parkinson's disease in time, and we look at REM sleep behavior disorders individuals, and we know that having REM sleep behavior disorder is highly predictive on neurological disorders, with 75% of conversion, not necessarily to Parkinson's disease, but other Parkinsonism as well. So research is interested in finding some markers or measures of gait or other things that are different in the early stage, to basically see if we can find anything that we can act on with drugs or other intervention to kind of like slow the onset. And at these early stages, we see similar changes occurring in a smaller scale compared to the ones that we see in early stage. So the arm swing range of motion might be different, and the asymmetry as well might be different. But there are some controversial papers, and the sample size tend to be small compared to other studies as well. As I was saying, this is kind of like all in the laboratory when one person might feel better and might show off a little bit. That's what we call. But in daily life, things might be very different, and we don't walk on a straight path in daily life, but we take a few steps. We turn around to the right, we turn around to the left, we sit down, we stand up, we turn around again. This is a recording coming from a GoPro camera placed on the waist of this individual, and this person is wearing sensors as well, and she's fixing herself a sandwich and getting something from the fridge while wearing the sensors at home. We do measure activities in daily living in some of our studies. We usually send 2 instrumented socks to wear in the feet and a sensor to wear on the waist, more or less where you basically wear your belt. And we ask people to wear these sensors for 7 days. And what we look at is those same walking and turning measures that we can pick up in the laboratory, but in daily life. And what we have found, and I'll explain this, so just be patient with me. So if we go to walking, and the pitch at initial contact is basically a measure of shuffling, how much you're shuffling your feet to the ground. Community is community or daily life, and lab is laboratory. And what we found in people in healthy controls, people with multiple sclerosis and people with Parkinson's disease, we see that the measures that we obtain in the lab, in the laboratory, tend to be better than those ones that we obtain in the in daily living. For turning, we see slow turns in daily life in people with Parkinson compared to healthy controls, but not necessarily if we do the same prescribed turns in the clinic. So there, we might be able to pick up a little bit more differences in daily life compared to the laboratory. So as I was saying, we use this instrumented socks prototype and a sensor on the lower back. And in this study over here, it is cross-sectional, but I wanted to look at that because it's looking at daily life measures. So you're walking and turning when you are doing the activities of your daily living, basically. And here we had a sample of 45 older adults with no known neurological diseases, 12 individuals with REM sleep behavior disorders, 23 individuals with untreated Parkinson's disease, newly diagnosed, and here are 27 people with moderate Parkinson's disease who were taking levodopa for several years. And what we see in daily life, we look at measure of quantity. So how much a person is walking, how much they are active, how many steps they are taking, as well as those quality of gait measures that I was looking at before. So those aspects of variability of gait, of asymmetry, of stability and rhythm. And in going to the results, here we have in blue the healthy controls, in red people with RBD, in yellow untreated people with Parkinson's disease, and in purple people with moderate Parkinson's disease. What we found is that when we look at the number of, a stride is basically 3 steps. When we look at the number of steps over 7 days and the number of turns over 7 days, we do not see differences in the quantity of those. Where we see differences starting early on is in the quality of those measures. So cadence is basically how many steps per minute, turning velocity, and double support time is basically the time that you spend with both feet on the ground, which is considered a measure of dynamic stability. We see that all those measures tend to be different in compared to healthy controls of similar age from early on in the disease. So, for example, there is a slower cadence across people with RBD, untreated Parkinson, and treated Parkinson. Turning velocity tend to be slower, and the double support time tend to be higher, even more so in those who have RBD compared to people with Parkinson's disease. And those aspects of gait variability that in the laboratory are worse from the beginning, from basically early on, during daily life, tend to be similar among healthy controls, people with REM sleep behavior disorders, and people with untreated Parkinson disease. Variability tend to be higher in people with moderate Parkinson disease. This is during daily life. We were also surprised to see this data, but in daily life, you do so much of different activities that probably there is a lot of variability among all those different activities as well. So that's probably why we don't pick changes in variability early on, but only later on. What do we know about progression? So those ones were all cross-sectional study, meaning that it's 3 different group of people, and we didn't look at them on time. There are a few studies that have looked at the same individuals over time and measured changes in the UPDRS score, which is that test that you do when you see your neurologist in the clinic, where basically you do these kind of motions and they pull you, and they exactly those kind of motions. And we also look at that overall measure of Parkinson's disease severity, as well as the gait and balance studies. There are not that many studies, we have to say. There are about only 10 studies that have looked at progression of gait. And the majority of them included people who were already on levodopa medication. So we do not have that many data on people that basically that starts looking at progression when someone is diagnosed. Those studies were called kind of the MODEP study, and this one was out from Europe. They found that walking speed declines about 2% in people with Parkinson's disease versus 1% in older adults. Because the other thing that we have to take into account is that there are changes in gait and balance as we age. For example, the vision is not anymore the same, or kind of like the vestibular system and proprioceptive system, those things change naturally. But it looks like in Parkinson's disease, the progression of those changes is faster. Another study that was out of the UK was called ICICLE. And as you may be aware, when your doctor does the UPDRS or Unified Parkinson Disease Rating Scale, when you do these motions, they also measure how much tremor you have. And we basically look sometimes at people who are tremor dominant or posture and gait and imbalance dominant. In the ICICLE study, they found that people that were tremor dominant showed a step length shortening and increased variability over time. But this is mainly due to the fact that those with tremor dominant were actually having better gait and balance to start with compared to those who have gait difficulties subtype of Parkinson's disease. Another study that came out recently from Oxford, it's called OHSU, and it looked at people with Parkinson's disease and people with progressive supranuclear palsy. And they found some machine learning way of combining gait and balance measure that they can track progression better than the UPDRS motor part. And doing a composite score of balance and gait, it's also common. There is another study called Watch PD from Takeda that look at composite score progression in time, finding that adding objective measures of gait and balance leads to being able to detect subtle changes that you can't detect with the MDS UPDRS part 3. Also because in the MDS UPDRS part 3, gait and balance are one item out of those other many outcomes that look at other things. What the other study that has a lot of longitudinal data in over 1,000 people is the PPMI study. They found that levodopa might mask progression, but people do progress a little bit over in time. And this is the graph that you see on the top right, where there is the Unified Parkinson's Disease Rating Scale total. In blue, you have people who are untreated, and in red, people who are treated. And we can see that those, sorry, the red one is the on levodopa, so, and the blue one is off levodopa. And you see that the on levodopa has a lower score, which means basically a better score if it's lower, but it does progress, meaning that it does go up on time. And here they looked at 36 months. So it's overall better, but it's not that the progression is stopped, it's just masked a little bit and is still happening in time. And we do know that people progress at different rates because of a lot of different variables. It could be genetic, it could be because they are exercising more, it could be because of all other reasons. And also we have what we see is measures from the upper body during gait discriminate better people with prodromal and early Parkinson disease from healthy controls. And the other gait and postural symptoms evolve more rapidly than other motor feature of Parkinson's disease. And also these are kind of questions that we don't know yet how to answer. We don't know if combining score and doing machine learning is really helping us in finding a measure that can reveal subtle changes compared to just looking at, for example, gait velocity or stride length or this aspect of things. This paper over here found changes in walking during daily living about 3 years before diagnosis of Parkinson's disease, using one sensor on the lower back, monitoring gait for 7 days. And so this one was not, the sample size was not very big, but it is an interesting finding that hopefully can translate in the clinic at some point soon. What we have found in our laboratory, and this one was a study that we did a few years back with about 20 people with untreated Parkinson's disease. We looked at changes in UPDRS more or less over 18 months, and we collected 3 measures. Some people will naturally start medication. They started untreated, and then they will naturally start medication at, for example, 6 months or 12 months. That is completely what we see. But what we observed during these 18-20 months was that regardless of people starting taking medication or not, the UPDRS score were not changing over the amount of time. But for example, the amount of correction that you do when you are trying to stand still were actually changing, and especially more in those people who did not start the medication. And probably that would mean that they will start medication later on, or that then with medication, that particular measure of static balance was early, was basically improved by taking the medication early on. Later on, we don't know what happens, but earlier on, it could be helpful. Similarly, in the same people, we looked at turning duration and arm swing range of motion. We observed that in people with untreated Parkinson's disease, turning duration tended to progressively increase at 18 months compared to the baseline, but it was already higher than in age-matched healthy controls at baseline. And the peak arm swing range of motion, so basically this is measuring the velocity at which you are swinging your arms, tended to decrease over 18 months. But it was also different at the baseline or 0 point that we have over here assessment. This is a study that is combining a lot of different studies and is out of Europe. What they found, they had a cross-sectional portion of over 500 people and a longitudinal portion for 33 people. What they looked at, and here in this graph, there are effect size. The larger the effect size, so the closer to 0.5 and 1, it means that the change was bigger. And if it's smaller or less than 0.4, it means that the change was small. We have 3 bars. One is approximating the MDS-UPDRS part 1. One is approximating the MDS-UPDRS part 2, and one the part 3. Oops, the one over here. So the part 3 is motor symptoms, and we see that in time, over 24 months was this study, the effect size, meaning the change of the MDS-UPDRS, was small because it was 0.3, while a measure of gait in daily life, a measure of gait quality, had a large effect size of 0.56, but not only gait during daily life, also the number of rotation that you do at night in your bed, that was changed. It was reduced over the course of 24 months. And here we have for the MDS-UPDRS part 2, which is basically asking you a lot of questions related to gait and balance and asking you the perception that you have of those symptoms. Those changes were not very high. And again, we have that the measures of gait collected in daily life that are in blue, and the numbers of rotation, or basically the rotation that you do in bed at night, had a large effect size. The MDS part 1 is more on kind of like autonomic functions and other things. And that one, the activity of quality of life, how much you are moving in daily life, had a larger effect size, more than the MDS-UPDRS 1. And you might ask why, and it's also because those questionnaires are a little bit subjective, and when there is something asked in a question, there is a scale in the questionnaire that goes from 0 to 4, for example. So there isn't much granularity. And instead, we think that with objective measure, that's what we can capture more, that granularity of differences. So that maybe it doesn't go in a difference from 1 to 2 when you answer to a question, but we can see something in the objective measure that is more precise than what a questionnaire can say. I was talking a little bit about levodopa before, and what we want to stress is levodopa is kind of like the main treatment that we have for Parkinson's disease in terms of drugs. There are others as well, but this one has been around the longest. In looking at those aspects of gait and balance, what we found in the lab quite a few years ago, and here we have on the right side, there is improvement with levodopa compared to off levodopa. And on the left side, we have worsening with levodopa compared to off levodopa. Measured in the same day in the same individuals, we see the arm swing range of motion, gait velocity, and aspect related to velocity of gait tend to get better with levodopa. So you basically are faster, swing the arms more, and so forth. But there are aspects of balance, static balance, and dynamic balance while walking that tend to not to change with levodopa or get worse. And that's why you also need to pay particular attention to your balance when you are on your medication, because you tend to be faster, but maybe not necessarily with better balance. And that's also why it's particularly important for people with Parkinson's disease to exercise. The disease is progressive. Medication and deep brain stimulation don't necessarily help balance. They help with some aspect, but as you saw, there are several aspects of balance and several aspects of gait. And some of them are getting better, some of them are not changing, and some of them are getting worse with medication. Also, exercise can help in avoid falls and fractures. There are some meta-analyses looking at falls and seeing that people with Parkinson's disease tend to fall 5 times more than people of the same age. And also sometimes women need to pay a little bit more attention as well if they have lower bone mineral density. And might be a more risk for hip fracture when falling. In addition, there are some papers investigating whether exercise can be neuroprotective for Parkinson's disease. The Parkinson's Disease Foundation came up some years ago with a recommendation for Parkinson's disease for exercise. And I think many of you might be familiar with those, but I thought it would be important to go through each of them and present a little bit of data that people published and some systematic reviews where possible. So we do know that one of the biggest positive effects of exercise is found over time in those who are suffering from Parkinson's disease. The recommendations are not to maybe focus on one exercise kind, but to do multiple of them, such as aerobic activity, strength training, balance agility and multitasking, as well as stretching. But you might ask, which kind of exercise? Because there are several, and also is based on your personal preference. We can see that this form of exercise is by sitting, and this is very different from this other form of exercise, where we have one trainer and one person with Parkinson exercising with a stick fighting. And this requires to use your balance constantly, while the other one is performed seated. Of course, these two are very different, but they might be very important in different stages of the disease as well. Going back to the recommendation from the Parkinson's Disease Foundation, one recommendation is to see a physical therapist that is specialized in Parkinson for a full functional evaluation. The suggestion is to exercise when you are on your medication. So you might feel more mobile, you might feel a little bit better overall. And to do 150 minutes of moderate to vigorous exercise per week. The key recommendation include the aerobic exercise for 3 days per week, which is this one over here, strength training, balance, agility, and multitasking, and stretching. I'm gonna go through each of them next. For aerobic activity, the suggestion is 3 days a week for at least 30 minutes per session and moderate or vigorous activity. And if you are not sure at what intensity you are exercising, if you can still talk and have a conversation while you are exercising, then you are not exercising at moderate to high intensity. Because basically when you are at those intensity, you can't really quite talk much. So there needs to be a little bit of that, of course, supervised or in a way that is safe for you. And why? It has been found, and these are systematic review, which basically mean that it's a research paper that is collecting from the literature all the papers that were on that same topic and making those diagrams that are called forest plot and looking at the effect size and seeing whether merging all the study together, done in a slightly different fashion, can result in improvement, worsening, or no change compared to a control group. So, and this is regarding motor symptoms overall. So think about the MDS-UPDRS part 3, which cannot pick up subtle changes, but big changes. Then this systematic review found some small but positive changes significance for the endurance aerobic exercise group versus the control group in changing those motor symptoms over time. This is not a long-term study. Think about short, about 6 months up to a year. Right now, there is a study called SPARKS-3 that is going on. It's particularly targeted to people who were diagnosed within 3 years and are not on medication at the time of diagnosis and at the time of joining the study, and is looking at whether there are 2 groups. People are randomized to treadmill exercise. One group exercises at 60-65% heart rate, and the other one 80-85% heart rate. And you actually do a fancy test to determine what is your real max heart rate. And then it gives you a prescription to do. And it's currently ongoing, and we are still collecting data in over 20 sites across the US. the primary investigator for this study is Daniel Korkos at Northwestern University. And I know there is a site in California as well. If you are interested and you look at Sparks on the web, you can find who to look for at University of California, San Francisco, for example. And if you know somebody in Oregon that is interested, send it our way. But this one is an in-person study. It's interesting that it's going on, and it's the only phase 3 study that there is on exercise. And phase 3 means that there was some evidence found in the phase 2 of motor symptoms improvement during the exercise. So this one is the phase 3 and is a 2-year-long study. In terms of strength training, the recommendations are to do strength training 2-3 non-consecutive days per week for at least 30 minutes per session. And this other systematic review found that doing the strength training improved muscle strength in general, but it also looked at some aspect of gait and mobility and balance, finding small improvements over there. So when I say small, it's a statistically significant improvement, is not particularly large, but there is an improvement compared to not doing anything or doing a passive control. Balance, agility, and multitasking, also important to do 2-3 days per week with daily integration if possible. And in terms of activity and kind of like agility program, I'm presenting a little bit of data from a study that we carried out here at OHSU a few years back. We did exercise with a lot of thinking, as I'm sure you are doing with Lisa and Steph as well, because it's very important. And it kind of like challenges you in doing 2 things at the same time and keep doing those things at the same time. What we did, it was for 6 weeks, and it was 90 minutes each session with a progression of challenging and complexity of the exercise every week. We did walking as kind of like a warm-up. We did power move, lunges, agility course where you put these lateral steps, cones to go around. We did a little bit of boxing, of Tai Chi. And then there was a lot of dual tasking. There was doing the agility course, but while saying the letter of the alphabet in alternate order. There was a little bit of set shifting, or kind of like saying punch with your right. And when we say right, then you mean actually punch with your left on the right of the instructor. So to get it progressively challenging. And also question is, should only people with mild disease do this kind of exercise? And what we found was actually no, everyone should do it, but we found more changes in those who had more severe motor symptoms, let's say, compared to those who had milder motor symptoms. That I'm not saying go tomorrow and do some like standing on one leg exercising by yourself, but it's just to say that maybe those one who had a little bit more severe symptoms had a little bit more room to benefit from this kind of exercise that we had in place. And not only motor symptoms, but also cognitive symptoms. Exercise is overall very important. Here we looked at a balance test, a balance clinical test, and higher is better. We found that exercise was significantly improving this balance test in those individuals with Parkinson's disease, and the education was not. And by education, it was basically the control group for this exercise. And this was a randomized crossover. So you either start with exercise and then switch to education, or you start with education and you switch to exercise. And the education was a 6-week program on educating on changes that you may experience with Parkinson's disease, nutrition, when to do your exercise, and things like that. We also looked at those fancy gait and balance measures versus the clinical measures that we collected. And we found that the effect size, so how much change we could measure in those 6 weeks, it was actually larger for those measures, for those objective measures of gait imbalance compared to the MDS, UPDRS, where we found smaller changes, but also because those are the MDS, UPDRS, there are things that you cannot measure compared to the gait imbalance. So the MDS UPDRS doesn't have a score for arm swing range of motion, for example. And we did find a lot of improvement in there. We found a lot of improvement on dual task gait speed. People were able to walk faster when doing another concurrent cognitive task compared to baseline. We found less shuffling and overall improved balance as well. Lastly, there is stretching, which is also recommended 2 or 3 days per week, with daily stretching being the most effective. And we talk about 10, 20 minutes. You could do some yoga poses, some dynamic stretching, Pilates or Tai Chi. And there are some exercise examples over here in the link that I left. But I'm sure if you do your exercise, maybe you stretch or relax a little bit at the beginning, at the end of it as well, which is a very good practice. Lastly, I want to talk about a little bit some of the studies that we have here that can be done virtually, and they do not involve coming in person. One study is called Digital Markers of Mobility in Daily Life to track progression in newly diagnosed Parkinson's disease. So the purpose of this study is to track disease progression with clinical and objective measure of mobility over 4 years. We do, of course, for the people that can come over here in the laboratory, we do a laboratory assessment of cognitive and balance measures. We also have the virtual option in which we do 2 Zoom calls, one at the beginning of 7 days and one at the end of the 7 days, to do a prescribed balance and walking test together virtually and to ask some questions. And we ask to do it in time as well. So baseline, month 12, month 24, and month 36. There is no month 38. Sorry, this one was a mistake. And what we ask you to do for 7 days at the time is to wear these instrumented socks that are like an ankle wrap, but they have socks over here and a sensor on the waist. The inclusion criteria here are not taking yet any levodopa medication, less than 3 years from diagnosis. Age is actually now 40 to 89. And this is basically hopefully will help us in finding those measures who are changing the most. Now, it's not yet that you have to stay without your medication for the duration of the study, only for the baseline assessment. You can start medication the week after. We anticipate people starting their medication whenever it's needed for them, because we know it's important. It's just that we would like to capture the first measure of any medication. And if you're interested in that, you can contact our coordinator, Ashley. And there is another study that is virtual, and this one is if you are taking medications for Parkinson's disease and you have not experienced a fall in the previous 12 months. We are at 80 participants, so we are almost done with this study. And also this one is 1 week of home monitoring with virtual study visits. But for this study, you also have reporting falls for 12 months. You have it for the previous study too, but this one is a little bit more, it's sending a survey every 15 days for 12 months. But in terms of commitment and in terms of what you have to do wearing sensors, they are the same. One is for people who did not start the medication, and we hope to monitor you for 3 years. This is for 1 year if you have started medication already and have not had a fall in the past 12 months. This is kind of like, I like to put it because I've been invited to talk, but actually I'm reporting the work of all the other members that are in the lab. Going from Lori King, the other co-director and a physical therapist, our scientific advisor and founder of the lab, Dr. Faye Yorak, and all our student postdoctoral fellows, PTs and research coordinators and everything. And here we have our funding sources from the NIH and from the Michael J. Fox Foundation. And here are all the people working with us. And I do want to thank you for your attention. I'm happy to take any question. And this is what we take at OHSU to go to work. It is an aerial tram. Many people ask me when I take a call from kind of like the bottom of the tram, if I'm about to go skiing. No, unfortunately, I'm about to go to work. But if you come to Portland and Oregon, this is a lovely spot where you can see kind of like all the surrounding mountains in a clear day. So please do not miss it if you come over to Portland. And I'm happy to take any question.
Wonderful. Thank you so much, Dr. Mancini.
There's some questions in
yeah,
the
we
chat
have a couple
there.
of questions in the chat. Let's see. Can you read them, Steph? You got it. Oh, I see. After taking carbidopa and entacapone for 5 years, I began falling a lot, often 10 times per day. We changed my script to Crexont, and my falls reduced dramatically. Yay. That's always good.
Yeah, that's great.
Okay, not a question. All right, next one.
Great.
We're very happy for you, Art. Next one. How important is diet in helping to slow down the progression of PD?
Oh, that's a very good question. I don't have quite an answer for that. I know that there were some trials looking at ketogenic diet, but I think the results were mixed. So I unfortunately can't answer to that question, but it is important, especially timing your medication. But it's not really my area. My background is in bioengineering, so it's diet. I wish I knew a little bit more on that.
All right. Next question. In general, would your results recommendations for exercise for diagnosed PD be the same for cerebellar ataxia?
No, they will be different. That's a very good question. The diseases are pretty different, and although they might share in common that there are gait changes and balance changes, the recommendation for ataxia would be a little bit different.
I had some comments. Keep having those questions if you have some, or you can raise your hand and we can help you ask that question.
Oh, here's a question.
Okay.
What is the impact of having other chronic diseases such as heart issues, blood pressure issues?
Yeah, so the blood pressure is also a good point, because some people have my experience, low blood pressure do sometimes to medication as well. And so you need to pay particular attention to falling, heart diseases, those things. It's basically things that you need to keep managed and under control. It's not necessarily that they have an impact on your disease. It's just that taking care of those ones might be a little bit more difficult.
Another question is, does DBS have an impact on balance or gait?
Yes. So there are some mixed results from the brain simulation studies that were longitudinal. Oftentimes, DBS gives back a lot of confidence, and necessarily you do not have markedly improved balance, but your speed, it goes faster, so you still have to pay attention to your falls. It is very, as you are aware, the disease is very heterogeneous, and some symptoms that some people experience, other will not. And sometimes the effect of the brain stimulation are very different from one person to another. It is a more of a complicated picture with cognition being in the picture as well. But said that, there are some studies out of Stanford finding very good results with what they call adaptive deep brain stimulation. So a deep brain stimulation that might changes the intensity on gait and freezing of gait. But it also depends on the site, maybe of the brain stimulation in the brain, whether it is in the nucleus subthalamicus or the globus pallidus. There might be differences in there as well.
And then what about PSP? Maybe just a quick comment about PSP and maybe falling backwards, or some comment about PSP.
Yes, we have another study with Dr. Marian Dale, who's a neurologist, looking at the effect of transcranial magnetic stimulation in the cerebellum to perhaps improve stability in people with PSP. People with PSP tend to fall backward more, and it's a disease that has kind of like a faster progression compared to Parkinson's disease, but exercise is still very important to maintain a little bit of quality of life, but the recommendation should be kind of like targeted, and definitely more physical therapy, more assisted exercise as well.
Let's see.
What about balance issues like climbing stairs and tendency to have weight back and pulling oneself via the rails?
Interesting one. Usually, sometimes people with Parkinson's disease, if they experience freezing of gait, they do not experience like climbing stairs, going on a bicycle, or doing other things. So that's an interesting one. Tendency to have weight back and pulling the rails.
Yeah. Anyways, okay. Maybe we can address that another time. I think that just has to do with not having the mechanism of weight shifting forward and not so much a balance issue, perhaps, or anything to do with freezing of gait. The next question is, if a person with Parkinson's has other issues on weaker foot, like arthritis and a fallen arch, would the usual fallen arch surgery, fusing two bones near the top of the arch, be okay or not? It's a complicated question. Have to be off the foot for 8 to 10 weeks, so no walking.
So I think that is something that needs to be discussed with your doctor, and you have to follow kind of like the best recommendation that you can. So if doing the surgery is the best option that your doctor suggests to you, I would say do it, and then make sure that you basically kind of like have a plan for going back to exercise, because 8-10 weeks without exercising are a long time. But if it's needed, then yeah, it should be taken care of. But it's, personal decisions together with the doctor and surgeon.
Yeah. I have a couple comments about your talk, which I found, thank you so much again for sharing it with us. But one of the things, that you just talked about was that you talked about that the quality of the steps change, not necessarily the quantity, especially when you're looking at progression, which is a really big thing, because a lot of people say, oh, I walk 2 miles a day. I still walk 1 mile a day. I walk every day with my partner. And that's great. But if the quality of those steps are changing, then wouldn't it be that they're actually maybe reinforcing what I would call bad gait, like shuffled gait, small arm swings, small steps? So being careful to understand, it's not just that you go for a walk, but it is really looking at the quality of the walking.
Yeah. And by looking at that quality, what we want to emphasize is that is exactly that what you said. Is like the quantity might not be different, but a person might still fall because of the quality. So it is good to go for a walk, but it's also good to exercise and kind of like maybe think more like a longer steps, larger arm swing. So all the good thing that in PT or in your exercise classes are reinforced to use those ones.
Right, and that goes to your comment or your point about how when you did the study looking at exercise first or education first, it's not okay to know that you need to take better and bigger steps. You need to actually go out there and do those better and bigger steps and physically do it, instead of watching webinars and understanding that, oh, I should be taking bigger steps. So we do encourage everyone to get out and to actually try those things.
That is true. I'm going to skip that one question just to go to this because it kind of has impact about walking aids. Have you evaluated any mechanical aids to walking, balance, or mitigation of impact of falling, such as airbags or robotic leg supports?
That is very interesting. So what we have in the works is a tactile feedback. So basically, it's a little device that gives you a tactile stimulation on the wrist every time that your foot is on the ground. We are evaluating the efficacy of it right now and the feasibility of using it in daily life. That is kind of like how we are putting technology to work for a different purpose, not to measure necessarily your walking, but to kind of like give you a reminder to pick up your foot, basically, over there. And so we have not studied yet the impact of falling on it or the mitigation of falling or freezing or more severe gait disturbances, but is ongoing. The there are, we have not looked at airbags or robotic leg support. I think there are some studies out from Canada looking at basically having some padded garment or piece of basic of pants that are padded around the femur and kind of like around the hips, and how they can impact and maybe prevent some fractures during falling in older adults. I'm not necessarily sure I know any specific in Parkinson's disease, though.
Thank you. Are there any studies or is anyone studying new or different treatments for freezing of gait?
So the tactile feedback that I just mentioned, we also look at that in people with freezing of gait. There is a prior problem to find if a treatment is working or not for freezing. It's also that we don't have currently very good measures for freezing of gait. There is a questionnaire for freezing of gait, but the changes that you need to achieve in that questionnaire are really big to find a change. So right now there is effort in basically finding better measures clinically. And also we are trying to see if improving turning, so doing a turning related exercise, can also improve freezing of gait. So more to come, hopefully, but there was a call from the Michael J. Fox last year specifically on freezing of gait, and there are about 10 to 12 projects. Some of them are targeting exercise, some of them are targeting cueing system, and some of them finding better measure. So hopefully in a few years there are some results out of that.
Good, excellent. Thank you. Is there a value in genetic studies is another question.
Yes, especially for disease progression, then genetic or kind of like GBA status or other things might impact how fast or slow the progression of the disease is. And so those are also very important studies.
Someone's asking about adaptive shoes, cadence. I don't know that. Have you heard of those shoes? I don't know that shoes. I know there are other shoes that have a vibration in it. It's like a little computer in your shoe that can help to kind of give you, like, again, another tactile cue to pick up your foot or have better heel strike or something like that. So yes, there are some shoes, but I think some of those things are over time, do you adapt to those cues and then ignore them? So
that's a good point.
Well, we really want to thank you. I do want to say, as just kind of a wrap up here, I think, one of the things, my takeaway point, that I think one of the many takeaway points, but you had mentioned that taking levodopa, the effect of levodopa doesn't actually, DBS and medications don't help with balance. Yeah. And that's a really important thing, right? DBS does not help with balance. Levodopa doesn't necessarily help with balance. What you said was it can help you move your leg better and maybe faster, but that doesn't necessarily mean that you're not going to fall. And so there's that cognitive component that when you're taking these medications and you can move better, yay, but you still have to pay attention. Are you moving in the right direction? Are you not? Are you carrying too many things? Are you on the phone and crossing the street and holding the dog? So those things I think are really important to me as take-home messages, that DBS and levodopa do not necessarily help with balance, but that you still need to really pay attention and work on some of those. You can work on your balance by doing the exercise to make your reaction time and your response times better through practice, but it does still take attention, and it doesn't just happen automatically with DBS or with the meds.
So the overall message is do keep exercising and exercise, because that's really important.
We love to hear that.
We do love to hear
We sure love when a guest speaker comes on and says, don't forget to exercise, because that's what we do.
And Lisa and Steph are going to make you exercise
and we're going to make you do everything and work on your balance
and make you count in Italian and all those
all that while you're finding balance, all those things. You got it. That's right.
We should count into Italian tomorrow in class.
That's a great idea. All right. Well, thank you so much, Dr. Mancini, for joining us today. We'd love to have you back again. This is great stuff. And anyone has any questions, please email us. You can check us out at pd-connect.org, sign up for our newsletter, or you can email us at info@pd-connect.org. Thank you so much for joining us, and we'll see you next time.
It is our first Monday of the month.
Yeah, this was our guest speaker series, yes. And check it out on YouTube, and chances are you're already watching it on YouTube. Just kidding. We didn't go live.
Thank you so much.
Thank you so much. Have a great afternoon, and we'll talk to you soon. Bye, everyone. Thank you.
Bye-bye.